Let's now bring to the stage Akshay Bhambri, an ICS Harvard Yenching doctoral fellow and STS fellow at the Harvard Kennedy School. He's pursuing doctoral research on the politics of medical knowledge in China and India, has held research positions at prestigious universities, and previously served as research manager at Harvard Business School, working closely with the government of India. Mr. Bhambri, the stage is yours.
Thank you so much. I can understand this is just before lunch, so everybody would be hungry. And I'll not take much time. I'll just take 1 or 2 hours, and then you can have your lunch. Just kidding. So thank you so much, Thomas, for inviting me and making me part of Presidium. And I think I understand that I'm the youngest one, but thank you so much for not discriminating on the basis of age and making me part of this amazing conference and congress. So today, I want to speak about a question that many health systems are wrestling with and all over the world, that how do we deliver effective, affordable, and equitable healthcare in the face of rising cost of aging population and burden of chronic diseases? One pathway that often gets overlooked in this conversation is the role of traditional complementary and integrative medicine. In this talk, I'll compare how 4 countries, Taiwan, India, China, and United States, have integrated TCIM into their health systems. And I'll argue that the case for TCIM is not only cultural and historical, but also economic and public health based, with evidence of cost effectiveness, quality of life adjusted, and return on investment. Before I begin, I think I would like to highlight a few of the disclaimers before my presentation. I'm really happy for Nora to give context to my work, because in my academic work, I work on problematizing the kind of evidence construction and the kind of scientificization that modern knowledge system talks about, modernity talks about. And I argue that these traditional medical systems have their own epistemology, which needs to be considered, and not be tested on the basis of the cost effectiveness, ROI, and other evidence construction that these modern knowledge system talks about. But I'm a political scientist by training, and I understand the value of speaking in the language that government, policymakers, and these big institutes understand. You can't talk to them in Chinese if they understand English. They will listen to you, but they will never understand what you want to say. So even though I problematize the kind of economic values and economic models talks about these things, I thought that it's a right time for me to build a model or kind of talk in their language to make them understand that this is the value of TCIM in modern world and public health systems. And this is what I'm going to present today. All the data that I have used is raw data for my calculations, and all the calculations are my own. So any mistakes in calculation, I owe them. And this is not anybody's or my institute or the conference organizer's responsibility. So now, before diving into the policies and cost effectiveness, let's pause for a moment and ask, why does traditional complementary integrative medicine matter right now? The number already tells us something very powerful. In China, there were over 1.28 billion traditional Chinese medicine visits just in 2023. That's almost 1 visit for every citizen, showing how deeply embedded TCM in daily healthcare system. In the United States, a very different health system, we see 36% of adults use some form of complementary and alternative medicine. That means over 1 in 3 Americans are engaging with these practices. In India, the connection is even stronger. About 70% of adults reports using some form of traditional and integrative practice, whether Ayurveda, yoga, or Unani. And in Taiwan, which we'll explore deeply, nearly 30% of population use TCM in just 1 year through the national health insurance. So this is the current situation in the world. You see that traditional medicine all around the world is being used extensively. So if many people already trust and use TCIM, how can we leverage it to confront the global health crisis? But before going into that, I want to ask, what is the global health crisis that we are talking about? If you see this is not, here we can see overall burden of disease globally measured in disability-adjusted life years. Non-communicable diseases shown here in blue dominate the picture. Cardiovascular diseases alone cost over 428 million dailies. Cancer and other diseases at 600 million dailies combined. Altogether, more than 1 billion healthy years of life we lost in 2022 due to these conditions. If you see over the period of time, these non-communicable diseases around the world have increased. And you can see in this, from 1990 to 2019, it has gradually increased. The crisis is also unequal. This chart highlights gender difference for women. Conditions like low back pain, depressive disorder, anxiety dominate the burden. So the global health crisis is not just about increasing chronic diseases, but also about the inequality that we face between genders, between regions, and between economies. To sum up this, rising chronic diseases, widening inequalities, and accelerating healthcare costs together define today's global health crisis. And this is exactly where TCIM can offer cost-effective and culturally rooted solution, not as a replacement, but as a complementary pillar of care. With high costs without equity show inefficiency, so TCIM can provide affordable, accessible pathways to reduce life expectancy gaps that you can see in this. Another problem that we face today is overdependence on antibiotics. The chart shows antibiotic consumption across European countries with average sitting around 16 daily doses per 1,000 person. In some countries, the level are far higher. But the result of these are, the consequence is resistance because of these higher antibiotic use. So we have this problem as well. Finally, we see how health burdens shift over time as countries develop, infectious disease decline, but chronic and lifestyle diseases rise. Yet inequalities persist. Women face greater burdens in different diseases. So the central question that I'm asking today is, how can TCIM be integrated into the mainstream public health system to enhance effectiveness? This isn't just a technical or clinical question, but also a question of policy design, health economics, and cultural legitimacy. Integration has often been partial or contested, sometimes reduced to pilot projects, sometimes sidelined by biomedical orthodoxy. So this central question is what guides the comparative policy that I'm going to talk about between Taiwan, India, China, and the United States. So let me just talk briefly about the objective of my presentation. First, I want to demonstrate the economic value of integrating TCIM. This is not just about cultural heritage and patient preference, though these matter, but about showing concrete improvement in cost effectiveness and return on investment. So I will be focusing on the economic value of these knowledge systems and these medical systems. Second, I'll share comparative policy insights from Taiwan, China, India, and United States. Each of these systems integrate TCIM in very different ways. And finally, the third objective of this presentation today is to policy relevance for universal healthcare system, health coverage. So now that we have talked about the context of this presentation, I will get into the country analysis, which is Taiwan, India, China, and United States. And I've been spending last 5 years all across these 4 countries, and I've been gathering data, doing my field work, and talking to different practitioners, policymakers around the world. In Taiwan, for example, integration of TCIM is much different from other 3 countries, which is more aligned with the national health insurance. In India, if you talk about TCIM, it's much more plural, and it's led by the Ministry of Ayush right now since 2014-15. In China, I think it's a leader in the integration of TCIM in public health system because they started early in 1950s, and the integration and standardization is much higher compared to other countries. And United States, even though their first encounter with TCIM was not in 1970s, a lot of people who think that it's 1970s, but it was early 19th century with the immigrant arrival in United States, and it has been engaging with these medical systems since then. As you can see, these data that the outpatient visits in Taiwan is over 70 million and 10.7 million unique patients. In India, 95% of people are aware of Ayush. Ayurveda is mostly used in India. In China, 1.23 billion people, as I mentioned, that have visited TCIM in last 1 year. And United States, 36% of adults use CAM, 49.2% among CAM users for pain management. And this is because of acupuncture, but it's increasing because for Ayurveda and other systems as well. So I'll go country by country and talk about their system and their cost effectiveness. I have very less time. I think I have 15 minutes, so I will dedicate 4 minutes to each country. Taiwan very quickly started early in 1950s and 60s, but it was more localized, and people used to use it through the local practitioners and not very much integrated in public health system. But 1963, NCRIM was established, and it was started institutionalizing. 1996 and 2001, when Taiwan introduced Taiwan's national health insurance, and by the way, Obamacare was based on the Taiwan national health insurance, so it's one of the most successful national health insurance system you can find all around the world. They integrated traditional Chinese medicine and gave it as much value as for biomedicine, and that changed a lot for Taiwan. During COVID-19, Taiwan extensively used traditional Chinese medicine, and it became a new point for legitimization of these knowledge systems in Taiwan. Through the numbers, I think I will skip this because there's so many things to talk about. But let's look at the main thing that I want to discuss today is about the cost effectiveness analysis that I conducted. Taiwan through the lens of cost effectiveness. Here I'm using the updated 2023 data from National Health Insurance. Hospital under biomedicine recorded 108 million outpatient cases with an average cost of just over 3,100 points per visit. Physician clinics are cheaper, around 739 points per visit. But what's striking is that Chinese medicine category with 44 million outpatient cases, the average cost is just 778 points per visit, which is just 25% of hospitals. So when we line up these side by side, hospital visit is roughly 4 times more expensive than TCM visit. This means expanding TCM use can reduce system-wide expenditure, free up hospital resources for adult care, and maintain equity of access while improving outcomes. So to be precise, this is how I calculated. I'm using the simple ratio of average expenditure. The average hospital visit costs 3,147 points, while a TCM visit is 778. We divide these and get the outcome, which is 24.7%. The policy implication is straightforward. If we appropriate cases are shifted from hospital to TCM outpatient care, you can yield around 75% cost saving per visit. Now let's turn to the very important thing, which is point value over time. As we can see here across most of these years, the point value of traditional Chinese medicine are constantly higher than those for hospitals. If you look at the ratios, they range between 1.15 to 1.35. In other words, Taiwan National Health Insurance was effectively allocating 15 to 35% higher value per point to TCM services compared to hospital-based services, which signifies that how policymakers in Taiwan value traditional medicine. So cost saving and quality enhancing, that again, that I calculated. On the cost saving, I have already dealt with, but I will go to the quality, which is a productivity proxy for health economists. It's a cheaper quality isn't alone enough. We also need to see if patients are actually doing better using the EQ5D quality of life index. TCM patient score 0.816 compared to 0.788 for non-TCM users. That's a measurable improvement in quality of life. Translated into QALY, that's about 0.28 QALY extra patient per year. And if we scale it up and compare it with 1,000 patients, that means 28 extra QALY. And 100,000 will make it 2,800 extra QALY. This shows TCM isn't just saving money, but it's enhancing population health outcomes. This is another study that I used for understanding and used their raw data to do my own calculations, but I think I will skip Taiwan for now and move to India. And India is a very interesting case because India, with the colonial encounter, saw the hegemony of modern medicine system being established while India was getting independence from British. But in 1950s and 60s, the integration of Ayush system remained marginalized. But since 60s and 70s, councils were made, and there were different reports that used to come, which advocated for Ayush system. But 1995, India saw a big change. Department of Indian System of Medical and Homeopathy created under Ayush. Integrating at the National Health Policy 2002, Ayush included as per pillar of primary healthcare system. But the big change that we saw was 2014 when Ministry of Ayush was made as a separate ministry from Health Ministry. 2020, during COVID-19, as any other country, we saw in India as well these changes, and I will not talk much about it. India, through the number, as per Ayush spending during NSSO survey, rural India spent 472 rupees per year on Ayush system, whereas urban spend 574 per year. Awareness, as you see, 95% of Indians are aware about traditional medicine and other system. The state has also invested heavily on Ayush in last 10, 15 years. Ayush allocations have nearly doubled in just few years from 1,939 crores in 2019-2020. It increased to 3,647 crores in 23-24. So the cost of effectiveness analysis that I did, I drew data from different sections, and this is where I focus on the osteoarthritis as a case study to assess the cost effectiveness of Ayurveda. The analysis drawn from a multi-center randomized controlled trial with 151 patients, where 77 were treated with Ayurveda and 74 with conventional medicine. The clinical outcome were measured using WOMAC index, which captures pain, stiffness, and functional limitation. Over 12-month of period, Ayurveda groups showed an average improvement of 61 points compared to only 32 points in conventional arms. This yields highly significant effect size of 1.78, indicating that Ayurveda provides a substantially greater clinical output. To translate these outcomes into cost effectiveness, WOMAC improvement were mapped onto the EQ5D quality of life scale, which function as QALY proxy. Here, Ayurveda produce additional 0.5 QALY gain per year, which is huge when you talk about a country like India, which is 1.5 billion people. When we compare cost, Ayurveda outpatient cost was 8,304 per year, while conventional care including physiotherapy, diagnosis, is around 10,000 annually. The result is that Ayurveda is not only improves quality of life more effectively, but also costs 1,696 rupees less per patient per year. Beyond the clinical trials, we can scale the analysis of population level. If 1 million patients were to shift from conventional care of Ayurveda to the health, from the health biomedicine to the Ayurveda, this is a direct saving of approximately 1.7 billion rupees annually, primarily from reduced drug and outpatient visits. if we talk about the broader public health system, if we situate Ayurveda in public health system, first of all, clinical effectiveness it provides. It has increased quality of life, as I showed with data, cost saving, as I showed with that, and equity and social legitimacy. We can talk about it separately. Third country which I'm going to talk about is China. And I think China, a lot of people have talked and a lot of people have written about it. But a lot of economic analysis is still being done, and people haven't realized without going to China that how China has been utilizing traditional Chinese medicine in last 70 years to improve their public health systems, and which is directly affecting their overall productivity, their economy, and other systems. So China, through the historical development, I think because of their communist commitment and their commitment against the Western hegemony, they started early in 1950s and 60s when Mao started standardizing traditional Chinese medicine. But I have to also highlight that the kind of traditional Chinese medicine that we see today is nothing traditional, because all the traditional Chinese medicine, even this term was invented during 1950s communist science. But at the same time, it was based on the traditional medicine that was used in China. But over the years, you see in 1986, they formed National Administration for Traditional Chinese Medicine. In 2016 and 17, the first law on traditional Chinese medicine was passed to standardize TCIM practice, and during COVID-19, they used it extensively. When we look at the China scale today, as I've mentioned multiple times, there are more than 1 billion people been using traditional Chinese medicine, and these numbers, I can provide these slides to anybody who wants it, and they can go through these numbers and see the scale of traditional medicine being used, and then they can talk to their own government and say that this is something that's happening around the world, you do also. But this is something that I have been calculating, and sorry. Yeah, so integrative TCM and medicine in breast cancer, and this is a study by Wang YK. I asked them for their raw data, and then I calculated it. This study was conducted in Guangxi University of TCM between 2018 and 2023, followed 226 patients across integrative and non-integrative arms. The quality of life indices patients in the integrative arm consistently scored higher across physical, cognitive, and emotional and social dimension. Clinically, the overall effective treatment rate exceeds from 90% compared to 79% in Western medicine-only group. When we move to survival outcome, the data becomes more compelling. At 1 year, overall survival were significantly higher in integrative group, with recurrence and metastasis rates correspondingly lower. Biomarker evidence collaborate these findings, and yeah, sorry. I got confused with this data because there is so much data. The IL-6, TNF-A, and IL-10 were more effectively regulated in patients receiving combined treatment. So through this study, you can see the combined treatment and TCM-only treatment was more effective. And if we talk about the ROI and cost effectiveness, we can see that productivity standpoint, each incremental gain in quality translate into the restored working days and social participation, amplifying the system-wide benefit. If we model this population level shifting, even 100,000 breast cancer patients into integrative pathways generates a substantial direct saving as well as indirect social gains. United States, I think I would not have a lot of time to discuss it, but as I said, that 1850s and 1880s was the first time when United States encountered these medicine system. But recently, you have that we can see in United States has been getting more and more legitimacy around different states, but they still need to improve a lot on different systems. If we talk about number, which I'm going to skip, but I'm going to talk about the cost effectiveness in United States. When we turn to cost effectiveness, systematic evaluation gave us the nuanced picture. The review over 330 economic studies found that nearly 1/3 reported both better outcomes and cost saving compared to conventional care. Cost utility analysis, often expressed COLI, also suggested meaningful gains. For example, in back pain, CIM intervention were found to be both cheaper and more effective, with an ICER that strongly favors adoption. What's striking here is not only the cost saving, often few $100s per patient per year, but the broader productivity and quality life improvement. These findings provide a stronger rationale for policy framework that treat CIM not as a adjunct, but as a viable evidence-based component in public health. There were 3 other things that I wanted to talk today, which was how TCIM can be really helpful when countries and public health systems face extraordinary situations where biomedicine still lacks in different research, and which was the COVID-19 case that we saw. Another thing was the toxicity and safety management that we see in India. And in Europe, for example, is toxicity management is discussed more than any other place. And we can, through the comparative study, we can see how other countries have been regulating the toxicity for these systems. And the third thing was the climate and sustainability, that how TCM in planetary crisis can restore and help us to mitigate and adapt to the climate change. In conclusion, there is no conclusion because this is this work that I have just started. And I think I would suggest everybody that even though everybody have been working on their own areas and doing great work as practitioners, as other people who have been working, but I think it's time to try compiling all the work around the public health system and pitch in the language that government and policymakers and economists understand, so that we make them understand that how TCIM can improve public health systems. Thank you so much. This is my email ID. If anybody wants to scan, they can scan it and contact me. Thank you so much.
Mr. Bhambri, thank you for a captivating comparison of policies on integrative and traditional medicine.